Welcome back to the next section of gastroenterology in our preparation for our endless quest to pursue and master our knowledge base in order to do well on step 2 and to serve a suffering humanity. Inflammatory bowel disease. Both forms of inflammatory bowel disease, both Crohn's disease and ulcerative colitis, have a lot in common. They're both idiopathic disorders that cause inflammation of your bowels. Now, in medical school, they tell us a lot about whether it's transmural or it's mucosal. There's granulomas and there's no granulomas. But let's start first with what do they have in common? Let's start first with what do they have in unity? Because if we see these two diseases as different variants of the same problem, it cuts what we have to memorize in half. Therefore, let's look at these two disorders as different variations on the same disorder. What do they both have in common? They both cause abdominal pain. They both cause diarrhea. They both cause abdominal bleeding. They both cause diarrhea and pain and bleeding. They both cause fever. What do they both have in common? They're both chronic, unrelenting, remitting, and relapsing. They are both chronic disorders of inflammation of the small and large bowel, or just the large bowel, causing weight loss, diarrhea, pain, and fever. And because of all this and the seriousness, weight loss. What else do they have in common? The extra-intestinal manifestations are identical. They both can give you joint findings. They both can give you eye findings. They both can give you skin findings. They both can give you liver disease. I know you've been told that only ulcerative colitis gives you sclerosing cholangitis. I know you've been told that. But they both give sclerosing cholangitis. Not based on whether it's Crohn's or ulcerative colitis, but based on how much is the degree of inflammation of your colon. They both give sclerosing cholangitis, not based on whether they're Crohn's or ulcerative colitis, but based on how much inflammation there is of your colon. If you have colonic Crohn's, you're going to get sclerosing cholangitis. And cholangitis is always going to be from ulcerative colitis. The extra-intestinal manifestations are going to be identical. Uveitis, iritis, pyoderma gangrenosum, erythema nodosum, pyoderma gangrenosum, erythema nodosum. That's a lot in common. They're both diagnosed with barium enema. They're both diagnosed with endoscopy. Both. Now, what is a little bit different? One is that ulcerative colitis is going to be positive for anti-neutrophilic cytoplasmic antibodies, whereas it's going to be negative for anti-Saccharomyces cerevisiae. Woo-hoo! Is that a long name? Saccharin, sweet, myces, fungus, cerevisiae, antibody. Well, A and A, an antibody, nuclear cytoplasmic, Saccharomyces cerevisiae. Cerevisiae, like you mean cerveza? Beer? That sounds familiar. Yeah, it's the organism that makes beer. It's the organism that ferments hops that makes a beer. And that is why Crohn's disease is anti-neutrophilic cytoplasmic antibody negative, but anti-Saccharomyces cerevisiae positive. You see the difference? Positive, negative, negative, positive. That means Crohn's disease has an antibody against the bug that makes beer. Now, what is that beer-making bug doing in your body? I don't know. Now, what's the difference between you not knowing and me not knowing? Well, I have deep ignorance, and you have superficial ignorance. You don't know, but you think somebody might know, or you could find it in a book. Your ignorance is superficial. I don't know, and nobody knows. My ignorance is deep. And that's the difference. We are here today to deepen your ignorance. I don't know and nobody knows why that bug is up your butt. I don't know. So that's just the way it is. How do we distinguish these without endoscopy between these two different disorders? Now, they are both treated predominantly with mesalamine derivatives. Now, mesalamine derivatives can be divided up into several forms based on packaging. Pentasa, you could say it's 5-ASA, 5-acetyl salicylic acid derivative, 5-ASA, 5-acetyl salicylic acid derivative. Or you could say it works for all 5 parts of the bowel. Stomach, duodenum, ileum, jejunum, and colon. 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 Ooh. Upper and lower. Stomach, duodenum, ileum, jejunum, and colon. That must mean that this works for Crohn's disease because it works up and down the whole bowel. Okay? 5-ASA or acetyl salicylic acid for all 5 parts of the bowel. Now, what about this? What about ascol? What part of the bowel do you think that ascol works for? Oh, I'm sorry, I misspelled that. Asacol. Now, what part of the bowel do you think that that works for? Was it better the other way around? It works for ulcerative colitis. Why? Because it's colonic ASA. ASA for the colon. Acetyl salicylic acid for the colon, or asacol. It works in ulcerative colitis. The other thing is ROASA, rectal ASA. Rectal acetyl salicylic acid. This is useful only for the most distal ulcerative colitis. Rectal, ROASA, is for the rectum, ROASA. Pentasa for all 5 parts of the bowel. Stomach, duodenum, ileum, jejunum, and colon. Stomach, duodenum, ileum, jejunum, and colon. Stomach, duodenum, ileum, jejunum, and colon. Asacol, colonic ASA. Rectal ASA. And you might say, hey man, where's our old friend sulfasalazine? Hey, anybody here seen my old friend sulfasalazine? Can you tell me where he's gone? Oh, what's the problem with sulfasalazine? Well, the problem with sulfasalazine is the sulfa. The problem with sulfasalazine is that when you have between 10 and 30% of the population allergic to sulfa medications, this is predisposed to causing an awful lot of, the 3 things you get are the 3 things. So, rash, well, yes, sulfa drugs giving you a rash, but not just a rash, drug-induced hemolysis. Sulfa causing hemolysis. Sulfa causing you to have renal problems. Allergic interstitial nephritis. Why, the only reason to take sulfasalazine is somebody says, well, I'd like to pee some eosinophils today. Yes. Well, can I pee some eosinophils? Sulfasalazine, allergic interstitial nephritis. Sulfasalazine. Now, sulfasalazine does exactly what mesalamine does, except that mesalamine does not kill you with sulfa adverse effects. Same efficacy, less side effects. What would you use? The answer is mesalamine. Now, steroids are used in these patients in the same way that steroids are used for acute exacerbations of asthma. Steroids are used in these patients in the same way that steroids are also used for acute exacerbations of asthma.